Good evening. Thank you for having me. My name is Siri Khalsa. I'm one of the neurosurgery spine faculty at The Ohio State University. This will be a talk on the direct lateral approach to the spine in the prone position using navigation, which is my preferred setup. These are my disclosures. I've done consulting for both of these companies, and some of their products are pictured in this talk. These will be the topics for this session here. So first, why a direct lateral approach at all? Why use navigation for laterals? And then a discussion of kind of the three ways to do the laterals, either single position lateral, prone lateral versus a staged approach. And then I'll be talking about some more of my own room setup, clinical pearls, and some questions that I frequently get from trainees on doing these optimally. So first, why a direct lateral approach at all? Well, first of all, you get an extremely large surface area for your implant, and the implant actually sits on the apophyseal ring. So that's an extremely hard surface that forms a column, a ring-like column around the end plate. And this is thought to be the reason why these cages have a lower rate of subsidence as compared to T-lift cages, which sit inside the apophyseal ring. This is one of the main reasons I like to use this for degen. Number two, it's a powerful tool for correcting coronal deformity. You have an instrument, a cob that breaks across both of the lateral aspect of the disc annulus, and then a cage that opens up the foramina bilaterally. You can see this is a case we did here in a staged fashion with multi-level L lifts to correct coronal deformity. And I feel like it's really simplifies that aspect of the correction. You don't have to rely as much on the posterior approach to achieve it. Number three, when you really want to avoid going posterior, this is maybe an extreme example that came here from an outside facility where there was a massive calcified fluid collection in the seroma or pseudomeningocele and a fusion within it in a patient who had developed adjacent segment disease and foraminal stenosis and was having medically refractory radiculopathy. He was also elderly and really wanted to avoid going through this posterior kind of complication here. And so you can see the result on the right. We just did a direct lateral along with the lateral plate and screws. This is probably an extreme example, but I think a more common example of not wanting to go posterior is, say, somebody who's had a previous laminectomy, maybe a wide laminectomy, medial fastectomies, and then they develop loss of disc height and foraminal stenosis. And so instead of having to work through the scar around the scarred nerve roots in the dura, you can just go in a fresh lateral plane. That's probably a more common scenario. Number four, again, a much less common scenario, but one that we've used from time to time, which is an anterior column release when you need a large sagittal correction. So this was a case, I'll talk a little bit more about this particular one later, came to us from an outside facility with a lumbar fusion with catastrophic hardware failure, but also a kyphotic deformity. This was a case wherein we used an anterior column release in the prone position via a lateral approach to achieve almost 30-degree correction without doing any three-column osteotomy. Another approach, another reason to do this lateral approach is when you have severely haloed pedicles. So this is a case where even inserting a 9.5 screw is still inadequate to achieve fixation at that haloed level. And so instead, to augment that particular level, we actually used a lateral plate with screws that traversed across the haloed screw tracts. Another, I would say, less common reason to do laterals is there's some unique advantages for corpectomies. This was a case where somebody had progressive conus medullaris syndrome from a worsening fracture that had been attempted to be fixated elsewhere, and those screws had failed and haloed, and so we decided we needed to do a corpectomy. And you can get a really large footprint cage, without having to navigate around the dura or the nerve roots. You can even achieve, in this case, we did a direct decompression from the lateral approach, including pulling the bone fragments away from the dura. I wouldn't ordinarily do this in an acute situation, but especially when this became chronic and progressive, this was a powerful tool to help him. So why navigation? So first of all, what do I mean by using navigation for laterals? I mean, you register a navigation system and visualize each of the tools you're using throughout the entire process with a 3D navigation monitor. So on the top left of the screen, you can see a more common use for navigation, which is inserting the pedicle screws through the perimedian incision. And on the top right of the screen, you can actually see that the navigated dilator is used to help you dock at the appropriate site via the lateral approach. In the bottom part of the screen, you can see a trial going across in a direct lateral fashion across the disc space. And so it's really every stage of the operation you're using laterals. I do also do periodic cross checks with fluoroscopy just to ensure accuracy. So why do that? Well, number one, it does help you avoid occupational radiation exposure. You also don't need to wear lead. So here, this is a picture of one of our cases where you have this imaging system performing the registration with everybody out of the room, with the exception of the patient. Number two, visualization, especially in high BMI cases. So this is a real case of an L4-5 LF that I did, where you have the pre-op CT scan showing disc space collapse, vacuum disc, and foraminal stenosis. She had symptomatic radiculopathy at this level and back pain. Then in the operating room, you see our localization shot with the fluoro, and essentially nothing's visible. And this was due to body habitus. And but we were able to get through the case using navigation. So we then took a spin with the 3D imaging system, and that did allow decent visualization of the vertebra, and then finally placement of the L-lift cage and perc screws. 3 is also a fluoro-related concern. Is I think when you're doing a direct lateral, and you can see this on the left side of the screen, that's from one of the technique guides. It's important to get essentially a perfect shot that allows you to work direct lateral, and that could involve rotating the patient, that could involve rotating the C-arm, and that's a major challenge, I think, when somebody has a scoliosis or a coronal deformity that especially includes axial rotation. You sort of have to do quite a bit of gymnastics to get that direct lateral shot, and I think that process is vastly simplified, and it almost feels like cheating when you use 3D navigation. So we talked about just the general topics of a direct lateral approach, and then why I prefer using navigation. So I'm going to get a little bit more into the details of positioning and how I normally think about picking prone versus single position versus staged. So in this slide, you see somebody in the traditional single position lateral. So this is by single position lateral, what I mean is lateral decubitus, everything being done in the lateral decubitus position. And the single position lateral, the lateral decubitus position is really optimal for the L-lift approach itself, but in my opinion, really suboptimal for placement of the pedicle screw instrumentation, which you can see in the bottom of the screen. So there's a few issues with this. One, the spine tends to sink a little bit as the case goes on, and that can lead to a few millimeters of inaccuracy. And if I'm going to have a little bit of inaccuracy, I don't want it with the pedicle screws. The second issue with that is that bottom, the contralateral screw is a real challenge to put in. You're essentially working from the floor. I will say that the use of a robotic arm has helped single position laterals quite a bit. but still I do feel that you are making the pedicle screw insertion riskier and more difficult. So we talked about the ergonomics of the cage versus pedicle screws. The other disadvantage of this position is a lot of people talk about is the alignment, specifically the lordosis. When somebody's prone on a Jackson frame, there's a natural, it's naturally induces a lordosis because the lumbar spine kind of sinks into the bed. And you don't get that in this particular position when they're lateral decubitus. In fact, and you're also introducing a coronal bend. Now, I think a lot of surgeons who do this, may find that they can compensate for these issues using the rodding, but nonetheless, it is a concern that's often discussed. And then finally, this is again a much more uncommon situation, but if the person has existing hardware that needs to be removed, I definitely feel that this position is suboptimal. Having to reopen and re-expose the posterior lumbar spine, while somebody's lateral is not ideal. So then these pictures here are depicting more of the prone lateral setup. So this is one of the vendors' prone lateral positioner. The patient sinks into it very similar to a Jackson frame, and in fact, it attaches to the Jackson frame. I don't think anybody could argue that a prone position is the most optimal position for screw placement. It's very familiar. The patient tends to remain still with regards to the placement of the pedicle screws. It's uncommon to have shifting as much as you get in the lateral decubitus position. That said, the ergonomics for placement of the actual cage is less optimal. But we're going to talk a little bit about how, at least in my practice, I mitigate that. We talked about how this position is more optimal for both sagittal and coronal alignment. And then finally, if you do have a complex case where you need to, say, remove hardware, then place a cage, and then place additional hardware, there's a case like that I'll present here shortly. You can do that without any sort of repositioning. And finally, there's the staged approach, where you do both. So first, you position the patient like this, you place the lateral cage, and then you flip prone and place screws. And I think that's actually probably the most common practice right now in general. You really just lose time in general, which at the end of the day, the most important thing is that you do the case safely. So if there are factors that make it necessary to flip, then you should do that. I will say that there are some cases where I think we decrease the morbidity significantly by avoiding a staged approach, and I'll present one of those cases shortly. And here we are with that one. So this was a case where we needed to remove this posterior hardware and then do an ACR to achieve the correction. So you can see intraoperatively, the old hardware has been removed, new hardware has been placed posteriorly. There's a temporary rod here. We complete the ACR and then place the new rods all in the same position, while achieving a correction. And this prevented essentially a front back. So in my opinion, we actually decreased the morbidity by doing this in a single position. These are photos from that particular case. You can see that the posterior incision was open at the same time as the lateral incision. We have a PSIS pin here to serve as the navigation reference. This is a little different from the setup I use now, which I'll talk about. You have the chief resident here working on the temporary rods, and I'm working on planning the incision for the lateral approach. And you're able to do this all simultaneously. I'll also note that for when you're doing an anterior column release, I did like having temporary rods in instead of having to rely completely on laterally placed instrumentation to prevent alisthesis. So let's dig in a little bit to the prone lateral room setup, some of the questions I frequently get asked. So first of all, just to clarify, the prone lateral from a technique standpoint is very, very similar. I mean, essentially, it's a lateral just done in the prone position. So all you're doing is instead of coming in this direction, you're still inserting your inner dilator, which should be connected to EMG stimulation to avoid the lumbosacral plexus. You're just doing it, working directly in front of you instead of facing the floor. But there are some nuances that this brings. So this is also from one of the technique guides. You can see, the surgeon is using a finger dissection to feel the psoas. I'll tell you, in my experience, I have never been able to reach that far in a prone position, just because of the way that the body habitus interacts with laying on the table. I think that the working corridor is deeper, and I rely on visualization rather than feeling the psoas. And so I use more of the setup on the right, where you actually have a long lighted handheld retractor that I advance and use to retract the peritoneum anteriorly, which usually falls down very, very easily, especially in the prone position. And then I visualize the psoas and then traverse it. So this is just a more close up of that tool that I find critical. I think multiple vendors have something like this, but you have a long handheld retractor and then a light that inserts into the retractor and lets you see very well. In patients with large body habitus, I might actually use two and have one of the assistants pull. I'll have the assistant pull posteriorly, while I pull anteriorly, or vice versa. And then again, the rest of the case is the same. You just have a different perspective. So instead of looking at it, in this orientation, you're looking at it in this orientation with the table-mounted retractor facing posteriorly. So some frequently asked questions I get. So can you achieve a similar coronal break when you're in a prone position? A coronal break is, you're bending the patient away from your side of approach to open up the interval between the iliac crest and the rib, to allow you to actually access the lateral annulus. And I think originally, before some of the more recent positioners came out, the answer was no, but I think now the answer is yes. This is one of the positioners. I know other vendors are imminently releasing something that achieves a very similar coronal break, but the patient lays on this prone and their whole hip leg girdle bends away, and then so does their chest, and you get a very aggressive coronal break. I actually don't even use the entire break it allows. So that's really not been an issue. So optimal setup to maintain navigation line of sight. So this was the old setup. This is what I showed in that prone ACR case, where I had the PSIS pin here, and then I had the eyes of the navigation system cranially, and then the retractor arm on the side of the PSIS pin. So while this worked for the case, I'll say the disadvantage is that if somebody is simultaneously working in the posterior incision, they will block your navigation with this particular setup. So this is how I currently set it up. The navigation is on the side of the PSIS pin. You can see how we drape this to expose the lateral flank. And then the retractor arm is on the head or arm side. And this allows somebody to work posteriorly without blocking the navigation, and it also prevents the retractor arm from blocking line of sight from the eyes of the navigation system to your instruments, and then also to the PSIS pin. Another issue, a little pearl that's not pictured here, is every piece of navigation equipment has this array on it, as you may know, and some of these arrays are flexible and can can face posteriorly, they can face caudally. The ones that are fixed caudally can run into an issue where they can become hidden in higher BMI cases as you insert the instrument. So I do think it's preferable if you can get one that can actually rotate and face posteriorly as you work, and it'll maintain line of sight all the way through, even when you're completely inserted into the spine. So when can L4-5 be done? Can it be done prone? Sometimes, right? And for me, the answer is honestly the same as if I'm going to do this in the lateral decubitus position. I use the exact same principles to determine whether L4-5 can be done. So, on the image on the left, we're looking at the iliac crest. You can see that the L4-5 disc space is just above the iliac crest. So that definitely can be accessed. In fact, that's one of the cases I showed earlier. A lot of surgeons will allow it to come almost as high as the pedicle. And if it does that, they believe they can break it and access L4-5, and I tend to agree with that. Then of course you must look at both the position of the psoas, which is pictured on the top right. This is the so-called Mickey Mouse ears, where the psoas is anteriorly positioned, and therefore the lumbosacral plexus is anteriorly positioned. And at least for a trans-psoas approach, this is not considered safe due to risk of damaging the lumbosacral plexus. That would be a no on the top right for a trans-psoas approach, at least. Then in the bottom right, it's a reminder that closely examining the vascular anatomy is critical to prevent devastating injury. So in this case, approaching from the right side would probably be risky, just because of the positioning of this particular vessel. From a psoas approach, this is fine. This is not positioned anteriorly, and you should be able to find a safe corridor that doesn't stimulate the lumbosacral plexus. I would approach here from the left. You just have to be mindful, when you're potentially popping through the other side, not to be aiming toward this vessel. These are actually from this particular image and this particular image are from the L4-5 LLIP I showed earlier. So then finally, when do I still prefer a lateral decubitus position? In spite of having become comfortable with prone and actually preferring prone, I still do lateral decubitus in certain cases. And so when? So one certain body habitus consideration. So I don't have a BMI cutoff per se. It's more where somebody carries their weight. So if somebody has a higher BMI and is more pear-shaped, where essentially the flank between the ribs and the iliac crest is where all the weight is, that will tend to be exaggerated in the prone position, and that might be a sign to just go ahead and do it lateral decubitus, and potentially stage it. And then sort of the number of levels and whether it's a stage 1 for large deformity. So if I'm doing 3 or 4 levels, I do find that the ergonomics of the prone position can catch up to you. Your shoulder can become tired. And in any case, I do prefer to if I'm going to do a long segment deformity, I do prefer to stage it anyway, doing the L-lifts on day 1 and then the posterior instrumentation and osteotomies on day 2. And so I'll just go ahead and do the L-lifts that are 3 or 4 levels in the lateral decubitus position. And then retropleural and retrodiaphragmatic approaches to the spine, I will still do lateral decubitus. We're talking about the lower thoracic spine, or in some cases the thoracolumbar junction. I will still do these lateral decubitus. It involves taking down the rib and then and working in a different plane than we talked about earlier. And then finally, lateral corpectomy is definitely still do in the lateral position. Well, thank you so much. Are there any questions I can answer?
Hey, it's Mike Selby from Australia. How are you?
Hey, great. Thank you.
Hey, that was good. Sorry, I only got on for about the last half, but I do a lot of prone lateral surgery and some regular lateral surgery as well, and indications are pretty similar to yours. I have started doing prone lateral corpectomies
Oh wow,
over the
okay.
last
Are
couple of
there
years.
any tips you can share? Anything different from doing them in
Yeah,
the lateral position?
yeah. So number one thing with a prone lateral corpectomy is that you treat it like two prone laterals initially to access the disc, and the risky part is really accessing the vertebral body because of you need to be able to control that segmental. So that,
Right.
yeah, other than that, it's actually a beautiful technique because with the prone lateral corpectomy, if there's bony fragments, so it's an old non-union of a fracture, or there's something that's heading towards the canal, it sort of falls down and it's much easier to get it. So, I really like the prone lateral corpectomy technique, but you also do have to be careful. You don't want to really pop the ALL too much. You want to thin things down. So there is a bit of care to be had there with the prone lateral technique, and always have a sort of aquamantis on hand for the lateral margin of the vertebral body where as you're peeling back the psoas, you do run into that segmental. But it's certainly very achievable and doable for a lot of patients. It's a nice technique. So.
No, yeah, I love that. No, thank you for sharing. I'll have to I'll have to give it a try.
Yeah, I think if you've ever, a great one to start with is the L3 level. Yeah, if you've got an L3, say non-union or really deformed vertebral body you need to remove. I think that's the really the perfect level for it, because the rib's not really in the way too much. You can get nice wide retraction. Um, I think sometimes other levels, particularly say L2, or you're going up higher, if the ribs are in the way, you've got to do a rib resection, particularly in older patients, to get them out. Which not everyone likes doing, but had to do a few times. So yeah.
Well, yeah, thanks so much, Mike. Yeah, that was really insightful, and um, I think knowing that you've had some success, I'm definitely willing to give it a go. Especially, I think what you said about the ease of bringing that ventral fragment down. I think was my main concern, but it makes sense that it actually might be easier.
Yeah, I mean, I often leave a thin rim back there as well, just because you don't want CSF really any time when you're doing these.
For
But
sure.
if you do have navigation, it can be enormously helpful as well for these cases. I don't always do them with navigation, but I think you just got to. Um, it is a good technique, and I think the ability to simultaneously control the posterior side and access the
Right.
anterior space is gold. So I've really enjoyed doing the handful I've done so far. But
Right.
yeah,
And
certainly it sounds like you've got the experience to make the jump.
yeah, you're right. This is definitely, I think, my preferred now. There's some weeks where we have 3 or 4 of these. Um, yeah, I think yeah, I feel ready to make that jump, especially if you've had success. And I also like the idea of you know, you can control posteriorly. You could place a temporary rod and kind of mitigate any issues if you do end up, destabilizing more than you wished with an ALL rupture. Um,
Yeah, and I know it's not for everyone, but when you do a bronchopectomy in, say, a semi-urgent situation where you can't really treat osteoporosis, you can load the vertebral bodies with cement through the pedicle screws. And so then when you expand a cage into that, you've got the support in the cancellous bone already.
right. That makes sense.
Which can be very helpful. So you're basically just using, cannulated fenestrated pedicle screws, filling those bodies with cement, and then you have a little more support when you expand that corpectomy cage against those end plates. Which, I do find these cases are done sometimes in quite osteoporotic patients that are in big trouble with a fracture that was meant to heal and never healed.
Right.
And they don't always have time for months of teriparatide beforehand if they're stuck in hospital.
No, that definitely makes sense. And yeah, no, it kind of speaks to the advantage of being able to control, ventrally, laterally, and posteriorly at the exact same time.
Thank you very much.
All right, thanks everybody.